I'm Dr. Perwinverb from Nantes.
That's fine.
Okay. Dr. Perwinverb, sorry, Mr. Chairman, dear colleagues, thank you for the opportunity to present the work. I have no disclosure. So there is a scarcity on the data in the literature concerning the robotic-assisted bladder neck artificial urinary sphincter implantation in male with neurogenic stress urinary incontinence. So we wanted to assess complication and functional outcomes of this technique. We performed a retrospective study in 3 different centers, and we assessed explantation and revision rate, and of course the continence rate at the end of the study. 14 patients were enrolled. The main voiding mode was intermittent self-catheterization. 4 patients previously had undergone artificial urinary sphincter with a bulbar urethral cuff. During the surgery, one implantation failed and the patient had secondarily pro-ACT balloons. One patient required conversion to bulbar urethral implantation. One conversion to open approach was required, and 2 patients had concomitant augmentation enteroplasty. One bladder neck injury was reported during the surgery. The follow-up was short, 8 months. One revision was reported. It was for a downsizing of the cuff. 4 explantations were reported, one related to early device infection in a patient who had undergone the concomitant enteroplasty, 3 erosions, and the patient had were proposed other strategy to improve the continence. Concerning the continence, for the patients who still had their cuff in a bladder neck position, the social continence was 100%, and the complete continence 56%. And in the overall population, the social continence was 86%. There is some limitations in our study. Its retrospective design, the short-term results, and the small cohort. And another important point was the heterogeneity of the experienced surgeon in the 3 different centers, especially robotic experience, which may explain the high explantation rate. This rate is higher than in the only one paper published on the subject from La Pitié. On 6 patients with a spinal cord injury, they reported no explantations. In this series, there was no augmentation enteroplasty in this paper. In conclusion, however, this is a safe and technically feasible technique, but long-term results are warranted. Thank you.
Thank you. Questions from the audience? Are you all very tired today? So, only men in the material, why no women?
No, because in women there is some series, but only 3 papers, so there is also a scarcity of the data. But the point was just to assess the technique in male, because it's a little more challenging, the dissection and the implantation.
And the dissection, do you go both ventrally and dorsally on the bladder, or only ventrally when you dissect?
First, we perform posterior incision of the peritoneum at the level of the vesicle, seminal vesicles, then down to the bladder neck, and after you go on the radius space, releasing the bladder, and so you, okay.
Do you think it's a problem to catheterize the patients? Is this responsible for the cuff erosions? Is it a problem, or is it maybe a better idea to have like metrophanostoma combined with the operation?
We don't have enough data to have an answer about this, but in fact, the trend to put the cuff around the bladder neck in this patient is to avoid erosion, because most of them are under intermittent self-catheterization.
You still had 3, right? But you still had 3 erosions, so
yes.
It's not completely safe.
Yes, you're right. But in the other paper, I just talk about, with a very big experience in robotic surgery and also in artificial urinary sphincter implantation. They had no abrasion. The follow-up is still short, but we have to wait more data and long-term follow-up to answer.
So we still do it as an open surgical procedure. Do you think it's a mistake, or what are now the advantages to do it robot assisted?
For the moment, maybe on the parietal aspects, and but we have to answer. We have to perform a randomized study.
So it was more a pilot study.
Yeah.
A feasibility. Emmanuel, I think you do it on a robot-assisted base as well, right? And you do it bladder neck procedures as well.
Yes, it's a paper she's referring to. My two comments is, first, the learning curve of the surgeons is something very important, and I do it with a very talented robotic surgeon. So probably it's part of the explanation, and definitively I guess the open surgery is a good route, but using the robotic surgery for this surgery, it changed your life, your vision, and the dissection. So definitively, except patients who are unable to be inflated for laparoscopy, probably we are moving definitively for laparoscopic robotic assisted surgery for this specific indication. Don't forget it's a rare indication. We do 3 to 5 or 6 per year in a big center, so it's not so much.
So do you agree with him?
Yes, of course. I totally agree, and we have to perform it only in expert centers, of course.
So thank you very much.
Thank you.